Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Dr. Michael J. Haller. He's a professor and a chief at University of Florida Health. And we're going to talk about his work in pediatric endocrinology. So, Dr. Haller, Michael, thank you for coming.
Thanks. Appreciate you having me on.
Yeah, please tell me about your work. Is it mostly clinical? Is it research? Is it a mixture of both?
Yeah, so I'm a pediatric endocrinologist, and my passion is type 1 diabetes. Most of my work is focused in trying to develop immunotherapies to prevent or delay the onset of type 1, eventually to reverse the disease. I spend about 70% of my time in that arena, and then the rest of my time is clinical and administrative work.
So when does type 1 typically strike people? Like at what ages, and what are the factors that cause you to have it or not have it at certain ages?
So type 1 historically has been thought of as what we used to call it juvenile diabetes, because it certainly affects a lot of children around school age and then again in the teen years. But that nomenclature was actually dropped a few years ago to just be type 1 diabetes, because it actually can happen at any age. The youngest type 1s are about 6 months of age, and we've had people develop type 1 diabetes into their 8th decade of life. So it can really occur anytime, and it's a really complicated disease. We call it an autoimmune disease because it seems to be characterized by T cells in the immune system that are attacking the beta cells in the pancreas that make insulin. But that's really a huge oversimplification, in that it has a genetic background, but genetics doesn't explain it all. It very clearly has environmental triggers, but those don't explain it all. And probably what's most frustrating and still fascinating at the same time is that there appear to be hundreds, if not thousands, of different pathways that ultimately lead to what we clinically know as type 1 diabetes. But because it's so complicated in that way, using sort of general approaches or specific therapies and applying them to everybody with type 1, doesn't really work. And so we're learning fairly quickly that, no two patients with type 1 diabetes really do have the same disease. And that likely means that they both require different approaches to trying to prevent that same disease down the road.
So what's different about someone that gets it when they're, 5 years old versus 50 years old? What's observed clinically or in research? What's been uncovered that's different?
Sure. The kids who get it when they're really young tend to have a stronger genetic component to their disease. So they're more often first-degree relatives of somebody else with type 1, so mom or dad, or have a sibling with type 1. And clinically, they have, by definition, a much more rapid course. They chew up their beta cells that make insulin much more rapidly. So they're much harder to effectively change the course of their disease. Whereas somebody who gets diabetes when they're 20, 30, 40, type 1 diabetes, by definition, has taken quite a while to get to that endpoint. And so they may have less of a genetic component to their disease, have a slower burn in terms of the severity of their autoimmune attack. And ironically, those folks may be more amenable to some of the immunotherapies we're trying to develop, simply because we essentially have more clock in the game to try to run up the score on them, as opposed to the young kids. Well,
someone that's, let's say, 50 that gets type 1 diabetes, how do you know it's type 1 versus not type 2? How can you tell?
Yeah, great question. It's not so easy to tell those things apart. Historically, we always thought of somebody with type 2 as being obese, probably having dark skin, being of Hispanic or African American background or Indian background, and having a strong family history. But that's not always the case. And similarly, we used to always think of type 1 as being a really skinny Caucasian kid who comes in with a very classic history of weight loss and inability to maintain their urine and thirst. But nowadays, we see very interestingly mixed pictures. So you see a 30-year-old, very mildly overweight, mixed ethnicity person with diabetes, and you can't just immediately label them as type 1 or type 2. So we most often use autoantibodies. So these are antibodies that are developed to beta cell antigens that are telling us that there's an immune attack going on to help us identify folks who we think really have more of a type 1 phenotype than type 2. But it's also not so uncommon to see both things occurring in the same patient. You get an overweight African-American gentleman in their 40s, you would most historically have thought that's got to be type 2, but we're finding out that maybe 5 to as many as 10% of those patients do in fact have autoantibodies, and so some component of their diabetes is driven by what we would think of as type 1.
So how does someone have to, again, I'm talking about more older people for now, but someone that's I'm just picking 50, they have either type 1 or type 2. Clinically, do they do different things? Do they eat different things? I mean, is the advice the same
really
for them?
Diseases. If you have type 1, no matter your age, you unfortunately are going to need to use insulin sooner rather than later to avoid developing the more serious complications of acute diabetic ketoacidosis. Whereas if you have type 2, you can often get by with some of the oral agents. So it does make a big difference in terms of making sure that you get the diagnosis as accurate as you can. In the younger kids in pediatric world, where it's pretty clear they have type 1, those kids need insulin the day of diagnosis. But some of these adults who have slow burning type 1 get misdiagnosed not infrequently, take oral agents for years, if not decades, and then finally, somebody says, man, this patient's diabetes is really hard to control. Maybe this is in fact type 1.
Well, besides the necessity of insulin, what happens to a person? Are there different comorbidities that arise, different lifespan or health span, related factors? I mean, what's different if you have full-blown type 1 or 2? You're taking insulin. What else?
Unfortunately, there's not a good kind of diabetes. Sometimes you'll hear that out in the community. You've got the good diabetes. They're both, pretty terrible diseases, unfortunately, and they both have serious complication risks associated with them. So type 2 tends to be associated with more rapid onset eye disease, that's retinopathy, kidney disease, nephropathy, and heart associated disease, vessel disease, so heart attack, stroke. But those things also occur in type 1 patients. They just tend to occur after more years of the disease. But because there's a bias towards people getting type 1 earlier in their life, again, both type 1 and type 2 patients face those same complication risks. And the key to mitigating those is maintaining really tight glycemic control for both. And then for the type 2s is also working hard to achieve a healthy weight and trying to make sure their blood pressure and lipids are well controlled.
So you spoke about immunotherapy. Does that mean immunosuppression, or what does immunotherapy mean and look like for these type 1s?
Yeah. So that space is my real passion. I've been working in this for the last 25 plus years now, where we're trying to largely repurpose drugs that are already out on the market that are used to treat patients with malignancies or rheumatoid arthritis or lupus or other similar diagnoses that we lump into autoimmunity, and see if we can apply them successfully in the type 1 space. So some of them are classic immunosuppressive drugs, which of course is a scary prospect and is one of the reasons it's been challenging to use them in type 1, because you in some ways would say you're trading one disease for another if you have to be significantly immunosuppressed for a long period of time. But what we're learning is that we can use some of these drugs in kinder, gentler, lower doses and still get really meaningful clinical outcomes for the patient that provide for some long-term preservation of their remaining beta cell mass. So some of them, again, are truly immunosuppressive. Others are more what we call immunomodulatory. They change aspects of the immune system, but don't leave the patients sort of classically immunosuppressed. And those are obviously of greater interest because they're typically more palatable to the patients and families who have to think about, do I want to, take my child, for example, who's recently been diagnosed with this, lifelong burden, and add on top of it some other drug. But, in the first 15 to 20 years that I was involved in doing immune therapies, we had a lot of strikeouts. We went to bat and just tried things that were generally pretty low risk, but they just didn't get us on base. But the last 5 years have been much more exciting in that the pendulum swung a little bit back towards considering the use of some drugs that are a bit more potent, but they're better than the ones we used to have, perhaps in the 70s and 80s. And so we're getting on base, and we might even be rounding second in that we're now having 4 or 5 agents that have shown the ability to preserve beta cell function in recently diagnosed patients.
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now back to the show.
We even have the first drug this last summer that showed we could delay and even prevent type 1 diabetes in high-risk patients, that being teplizumab. And so, that drug is now on course to potentially be the first therapy to get an FDA label for changing the natural history of type 1 diabetes, something that we haven't had, and we're coming up now this year on the 100th anniversary of the discovery of insulin. So, it's exciting to be able to say we're nearing paradigm shift where we don't just have the single tool of you got diabetes and you're going to have to take insulin, but we might be able to actually change that disease for folks.
Well, how selective is the immune response? Does it target the entire islet or only the beta cells within the islet?
The immune response in type 1 diabetes does appear to be pretty darn beta cell specific, or at least that's the classic teaching. But over the last few years, we've also started to learn that the entire pancreas is sort of in on the game. We found that, for example, the weight of the pancreas, when we were able to get pancreas tissue from organ donors who've lived with type 1, is reduced by more than 50% compared to patients who don't have diabetes. And when you look at the exocrine pancreas, that's the part of the pancreas that makes all your digestive juices, not just the endocrine pancreas, which is the part that makes the insulin, the beta cells. The exocrine pancreas is also markedly reduced because the endocrine pancreas makes up only 2 to 3% of the pancreas. So when you see the volume and the mass of the pancreas being reduced by that much, it has to be reflective of the exocrine pancreas. So the thought is, that might just be related to the lack of local insulin as a growth factor, but we're currently doing studies to look at live tissue slices from these organ donors to help us understand, is there really maybe a little bit of an immune response in the exocrine pancreas as well? The jury's still out on that, but that may end up being the case.
Well, I've heard when pancreases are observed that literally beta cells are just not there. You have islets, I guess, that are devoid of beta cells, but there doesn't appear to be any scarification or fibrosis or anything to show that a beta cell was once there.
We do sometimes see that. And again, this speaks to the heterogeneity of type 1. We're fortunate here at the University of Florida to have been the site that started this program called the NPOD program, which is the National Pancreatic Organ Donor Program. And we work with the organ procurement organizations that when unfortunately somebody's going to be considered an organ donor, they contact us, and if the organ can't be used for clinical transplantation for whatever reason, we get it. And what we're learning from this is that the textbooks were frankly wrong about so much about type 1, especially because a lot of what we look at when we see pictures of histology for type 1 is really not humans. It's often animals, and the mice models that we use are quite different. So long story short is it looks different in many different patients. Sometimes there's fibrosis. Sometimes there are lots of beta cells there. Sometimes there are very few. Sometimes there are beta cells that actually still make insulin. Other time there are beta cells that are devoid of insulin. So it's really fascinating. I think it speaks to this idea that type 1 diabetes is not a single disease. It's really a collection of many different diseases that we'll probably discover down the road are so heterogeneous that they literally represent individual sort of pathways for each patient. And that makes immunotherapy, a really challenging question. Once we know enough, you would probably say, all right, I'm going to identify this patient who has this kind of immune response, whose pancreas is this big, who has this kind of background HLA, this genetic risk score, and they're going to get therapies X, Y, Z. And somebody with different characterization is going to get, therapies A, B, and C.
So this label of type 1 needs to be divided into, I guess, phenotypes or subtypes of type 1 to be able to be addressed properly.
Absolutely. And that's where we are at now. Clinically, if you ask, your seasoned folks who've been taking care of patients with type 1 for 30, 40, 50 years, they kind of know that inherently, but we just haven't had the tools, I think, from the basic science point of view to really kind of flesh that out. But we're getting better and better at that. And so the hope is we can apply those tools to these patients clinically, and preferably in the pre-type 1 space, so that we can prevent their disease.
So what does the histology of the exocrine part of the pancreas look like? Is there any patterning or evidence of anything going wrong?
Well, that's what I was saying. We're still trying to learn that out literally as we speak. We have a couple of new grants that are designed to understand that. So one right now that we're doing is using non-invasive imaging of live patients, so via MRI, to help understand what the pancreas looks like, both in size and in sort of characteristics. And then we're using some of these live tissue samples that we get, where we get slices of pancreas, to help better understand what the beta cells look like, but as also the exocrine pancreas. What it looks like now is mostly that the exocrine pancreas is just shrunken down. We're not seeing a whole lot of specifics yet, but there's
is it shrunken uniformly? Like, is the head or the tail bigger or longer or shorter?
There are some differences, and it looks like it shrinks from the tail towards the head. So, and why that might be is still kind of to be determined.
What cells constitute the exocrine pancreas, and are the islets just randomly distributed throughout the pancreas, or are they focused in certain areas of it?
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
They're spread throughout the entire pancreas, but they tend to be more enriched in the head. And so when you look at a full pancreas, you can see them in different places, but it varies by patient.
Okay. So the only thing observed so far, and you're studying this further, is that the whole pancreas is shrunken in people with type 1.
Yeah, that is a fair observation. And it's like I said, it's a pretty remarkable difference. A control patient versus somebody with type 1, same size, the pancreas will be half the weight, half the volume.
Well, what about longitudinal imaging, non-invasive stuff of people when they first get type 1 and then stay with them for a number of years and see if their pancreas shrinks or changes shape?
Yeah, so that's work that we're doing as we speak also. So we just fortunately got a grant from the NIH to study this question of what really happens over time in patients who have type 1. From our previous studies, it looks like once type 1 has been diagnosed clinically, most of the pancreas volume reductions already occurred. There's a group at Vanderbilt and some other groups who are studying this as well, and they have some data suggesting that the volume might continue to decline. Ours doesn't show that yet. But what our group's really interested in the patients who have pre-type 1, because what we found in our initial studies was that even a family member of someone with type 1 who has no autoantibodies, so no discernible risk for type 1 in the near future, other than that they are a family member with type 1, their pancreas volume is already reduced compared to somebody who's a true control, somebody who has no family history. So that to us suggests that there's a genetic background for having a smaller pancreas, and that might be part of diabetes risk. And then as you go to folks who have a single antibody or a multiple antibodies, as they get more high risk for developing type 1, the pancreas volume sort of is reduced in a stepwise manner if you look across the groups. What we don't know yet is how that translates to change over time. So now we're recruiting patients to follow up with us and to be seen at a baseline a year later, and then hopefully thereafter, to better understand, what is the rate of change in pancreas volume in folks who are likely to progress. Because the hope would be we could use that as a fairly cheap and relatively non-invasive tool to add to this effort to get towards personalized medicine. We'd say, your pancreas is whatever percent of normal, or your pancreas is actually completely normal, and therefore we don't need to be considering this aggressive therapy in patient A versus patient B. Again, we're not quite there yet, but that's what we hope these tools will allow us to do in the not too distant future.
Does anyone understand the epigenetic marks associated with pancreatic function? Like if you look at type 1s or if you look at normal people over the course of their lifetime, again, do we know the genes responsible for pancreatic action? And then again, epigenetically, when they get marked up, do we understand the up or down regulation of them? So
the short answer is no. That's an area of great exploration right now. There are clearly a lot of epigenetic factors involved in type 1 progression, both pre and post diagnosis. But, the single greatest factor genetically in predicting type 1 risk is HLA type. So the overwhelming majority of patients have a high risk HLA. And then there's, 40 or 50 other genes that have been associated with type 1 risk, but HLA by far drives that. And so, we are getting to a point where you can develop these genetic risk scores that use HLA plus some of these other SNPs these other markers, downstream of that. But adding in epigenetics to the mix again will hopefully get us to a point where we can really better understand what two people with type 1 standing next to each other that we call the same thing, how their diseases really do differ and how they may confer risk to their offspring.
Okay. In terms, you said that you can use an antibody test to see someone who's older if they have type 1 or type 2. So if you're able to do that, I mean, the beta cells in particular are affected most strongly. Has anyone attempted to classify like all the receptors that tend to be on the outer membrane of these cells and then antibodies that would interact with them? And like how much drilling down has there been on beta cells in particular to look at what are the targets of the immune system for the beta cell in particular and how it's affecting it?
So I understand your question correctly. Yeah, I mean that is the basis for measuring autoantibodies. These are antibody responses to antigens that are on the surface of beta cells. Some of them are functional, like glutamic acid decarboxylase. Obviously that does some work inside the beta cell. Others are purely just antigens that define the beta cell for what it is, like insulin for an action, but outside the cell itself. So people have been working, very diligently at better understanding the beta cell itself, because while I sort of intimated at the beginning of this conversation that we treat type 1 as an autoimmune disease, and I still firmly believe it is, there's no doubt that the beta cell itself is complicit in its own demise. It is a disease of the beta cell, not necessarily a disease of the immune system. And there are some who argue quite reasonably that, the immune response, while obviously defining the progression of the disease, might in fact be secondary. And that the primary disease is the beta cell itself being defective. And because of that, action, it's what triggers the immune response. There's a whole group of folks who consider themselves beta cell biologists who you might argue, the beta cell is the end all be all of it. And then there are others who are immunologists who say, oh no, this is purely an immune mediated disease. The HLA definitions show that, the ability of immunotherapies to augment the disease show that. And then there's the reality, which is probably it's a mix of all those things, which makes the darn thing, very tough to solve. Again, for groups of people, let alone any one patient.
But again, like you alluded to earlier, it's heterogeneous to the disease, and there's probably a bunch of major subtypes of it. So, thinking about it only in one way is a mistake. But are you able to isolate purely, the immune component of type 1 for at least one of the subtypes that you see?
Yeah.
How finely do you need to approach this?
That's a great question. If nothing, I'm a pragmatist. And so while I love the science and be able to say, you have type diabetes 1.69346, it might be good enough to say you have diabetes 1 point something to the 10th and apply therapies, because all of our studies to date have really done just that. And we're still able to show some benefit for a majority of the patients. That being said, the therapies we have are still kind of crude, and we are working hard to make them more specific and targeted and not affect the entire immune system. So they are truly more immunomodulatory than immunosuppressive. But it would be, certainly pie in the sky to be able to understand somebody's type of diabetes that specifically and know we could give them a very specific therapy that would help them. But it may be unnecessary to get at that level of detail in the clinical world if we can get drugs that work. I think the other major thing that we fight with in the type 1 space is historically, we've treated patients in research studies with a single therapy one time, and then we see what happens. But that's not the real world of how you treat almost any other immune-mediated disease. Most of these require repeat therapy or even constant therapy. It's just that in the type 1 world, once we kind of commit to using insulin, people think, well, insulin is the therapy. And of course, if you don't have enough beta cells around you, you absolutely have to have insulin. But if we could be involved in the process earlier on, which is happening now because we're able to do autoantibody screening in larger populations, people are starting to even initiate autoantibody screening in the general population. We're going to have this big group of folks who we know are heading towards clinical type 1, but we might be able to, again, change that natural history if we're able to give them a therapy. And it may not just be a therapy. It may be therapy A when they're 5 years old, and then therapy B when they're 6 years old, and then, continuation of therapy C, thereafter, as long as it's low risk and well tolerated. But that's, very analogous to how you treat things like rheumatoid arthritis, whether it be in kids or adults. So I think that's where the field is headed in the not too distant.
How difficult would it be to examine like all the surface features of beta cells, in a population of people? Would that be like an incredibly difficult task? Would that even provide any useful information?
It's really impossible. As my friend and mentor, Dr. Desmond Schatz, says often, why the good Lord put the pancreas where it is and the beta cells where they are, is one of the great mysteries of life, and makes it a huge challenge. You just can't get tissue from a patient easily. It's not like you can go do a skin biopsy and get all the answers you want. And so that certainly has limited the field incredibly over the years. And again, why the NPOD study is so exciting and helping us to rewrite the books, because we're able to actually look at the real tissues instead of trying to extrapolate from animals. But like you said, it may be really cool and novel basic science, and that always ultimately ends up improving our understanding of the world and down the road, and improving our ability to change the lives of patients. But those kinds of efforts are a much longer time horizon. And as a clinician, I'm also very impatient. And so I'm looking forward to having things I can use now. And I'm of the mindset that, they don't have to be perfect and they don't have to be so personalized, as long as they provide a benefit to, the majority of patients. And like I said, we're right on the crux of that with drugs like teplizumab, drugs like low-dose anti-thymocyte-globulin, which I've been studying with our team here for the last decade with extremely good results. Recent data from a drug called Symphony, golimumab. That's a drug that's approved down to 2 years of age to treat, again, rheumatoid arthritis in kids. We had excellent results with that drug in new onset type 1. So I think we're finally getting some more tools in the toolbox. And over the next decade, I hope we learn how to apply those tools, either alone or in combination, to really make a more meaningful change for folks living with type 1.
If when I understand drugs ending in MAB means a monoclonal antibody,
yeah,
I'm not very familiar with it, but for listeners, can you express what's the method of action of the MABs, the monoclonal antibodies? How do they work?
Yeah, so these are engineered drugs essentially. So these monoclonal antibodies, mono meaning one, clone is a type, and an antibody. So they're really designed to be these sort of heat-seeking missiles against a particular marker, typically on a cell surface, and they go after either a marker on a cell or a receptor, and they destroy or block it. So just for example, teplizumab, which is an engineered monoclonal antibody against the marker cell determinant 3. So it's a marker that sort of defines T cells. When you give this antibody, it goes out and binds to the CD3 and causes the T cells to ultimately be destroyed. And so, it's certainly not particularly specific immunosuppressive agent. It's pretty generalized. But when given at the right dose, it appears to provide for some degree of immune reset, and it very clearly results in preservation of beta cell function for these patients. In this recent study I mentioned, it's now been shown to delay progression to clinical type 1 in very high-risk patients by 2 to 3 years. You ask anybody living with type 1 and ask them, what value would there be in delaying the onset of type 1 by 2 or 3 years, they'll laugh and tell you, I'd pay almost anything to have had a couple extra days without type 1, let alone that period of time. So again, we're not at the point where we're curing disease, but we're getting closer. So these monoclonal antibodies, and then they're being developed against every single kind of marker you can think of, pathway you can think of involved in type 1. You can understand how you should be able to logically apply them either in series or sequence or combination to further augment the disease and get us to a point where we can stop it from progressing and save people from having to need insulin at all if we do it early enough in the process.
Well, what's the method of action by which these monoclonal antibodies slow the progression of the disease? Even in rheumatoid arthritis, why does it work in general? Yeah,
well, so at the end of the day, it works because if you get rid of the T cells that are ultimately, in the example of teplizumab, the T cells that are, they're ultimately responsible for attacking the beta cells directly and destroying them. It's just like losing soldiers in a battle. You take out somebody's entire platoon, they're less likely to cause you damage. So you're taking out the bad guys. Another example would be rituximab. That's an anti-B cell agent. We always talk about type 1 as being a classically T cell mediated disease, but the B cells have to talk to the T cells for the T cells to know what to do. And so that's like cutting out, somebody's communications team in the middle of a war. If I take out the B cells and they can't tell the T cells what to do, essentially I've also handicapped that platoon. And so that helps you preserve your beta cells for longer. Polyclonal and monoclonal antibodies being developed to all these different targets to try and stop disease. I mentioned briefly anti-thymocyte globulin, which is one of my drugs of choice because I've done the most work with it. That one's actually a polyclonal antibody, and it's not really made in a designer way. It's made the old-fashioned way. We literally take thymus tissue from kids who are having heart surgery typically, put it in a special colony of rabbits that then make a mix of antibodies to all the different T cells that come from that patient's thymus. And then you can purify the rabbit's antibodies, and now you've got this mix of antibodies against every single marker on a T cell, not just the CD3 marker. And that's a drug that's used every day in any large hospital for kidney transplantation, kidney rejection, pre-treatment for chemotherapy. We've been able to show that applying that drug at a very low dose in type 1 patients also provides for at least 2 years of beta cell preservation in newly diagnosed patients, and are planning to move that into a prevention trial here as soon as we get past the elephant in the room of COVID.
Okay. Well, very good. Michael, what's the best way for people to find out more about your work? Where can they go?
I invite people to visit the University of Florida Diabetes Institute website. You can come there. I am happy to take emails directly. You can email me. My email is publicly available on the webs. Most folks can find it if you go to the University of Florida Diabetes Institute. And I'm happy to answer questions directly if you don't find the answers to what you need on our website.
Very good. Dr. Michael Haller, thanks for coming on the podcast. I appreciate it.
Yeah, pleasure.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.